Good afternoon and good morning to you if you're on the West Coast. My name is Jose Leon, Chief Medical Officer at the National Center for Health and Public Housing. Thank you for attending this webinar, Diabetes Self-Management, Education and Support. This webinar is being recorded and all the resources, materials, the slides will be sent to you after the webinar is over. We are going to have a Q&A session after the presentation. You can either use the chat box or you can use your raise hand icon and then your line will be unmuted. The mission of the National Center for Health and Public Housing is to strengthen the capacity of federally funded public housing primary care health centers and other health center grantees by providing training and a range of technical assistance. There are over 1,400 FQHCs across the country. According to the 2018 UDS data, they serve 26 million patients. 356 health centers reported patients who are in or immediately accessible to public housing, and they reported they serve 3.4 million patients. Of the 356, 106 receive federally money to provide services to public housing patients, and in 2018 they served over 671,000 patients. A little over 15% of health center patients have diabetes, and 32% of them have poorly controlled hemoglobin A1C. Public housing grantee patients, 9% of the public housing grantee patients have diabetes, and around 33% of them have uncontrolled diabetes. So before we get started, we would like to just do a quick poll, and we would like to ask all attendees if your health center have a DSMES program. So Fide, can you please open the poll? We're going to give you around 30 seconds to complete the poll. All right, can we see the results?
Yes, so far 36% said yes and 64 said no. 64% of attendees said no.
Okay, so this question is for the 64%. If you answered no to your first question, are you collaborating with other community organizations to provide DSMES? We're going to wait for 15 seconds. Excellent, thank you. Can you please close the poll and let us know the results?
Yes, 39% said yes and 61% of attendees said no.
Great, great. So this is a great opportunity for those who answer no to hear from Dr. Andrew Reinhardt. Dr. Reinhardt serves as the Chief Medical Officer of Glitech, an enterprise software company specializing in diabetes therapy management. Prior to joining Glitech in 2015, Dr. Reinhardt was in clinical practice for 20 years. He served for 7 years as program director and diabetologist at Johnston Memorial Diabetes Care Center in Abingdon, Virginia, which is part of Mountain State Health Alliance, now Ballad Health, the region's largest health system at the time with 13 hospitals. He also served as physician champion for the health system's inpatient glycemic control initiative. Dr. Reinhardt received his doctorate degree from the University of Maryland School of Medicine and completed his residency at East Tennessee State University. Although trained in internal medicine, Dr. Reinhardt was inducted as a fellow of the American College of Endocrinology based on his expertise in the field of diabetology. He is a current member and past chair of the American Diabetes Association's Primary Care Advisory Group and has served previously on their professional practice and prevention committees. Dr. Reinhardt was the first physician board certified in advanced diabetes management. He serves as a content expert for the BC ADM exam and sits on the BC ADM exam oversight committee. He is also a certified diabetes educator, and as a physician CDE, he has served on the 2012 and 2017 National Diabetes Self-Management Education and Support Standards work groups and remain an active volunteer with both the American Association of Diabetes Educators and the American Diabetes Association. Dr. Reinhardt has been awarded recognition from the National Committee for Quality Assurance Diabetes Physician Recognition Program for providing high-quality care to persons with diabetes from 2002 until leaving clinical practice in 2015. He is also a co-inventor on a number of patients-related to diabetes therapy management software. Without further ado, I turn the presentation over to Dr. Reinhardt. Good afternoon, Dr. Reinhardt.
Well, thank you so much. I was telling beforehand, I said, unfortunately, when you have a bio that long, that just means you're old and you've been doing this for a while. So we'll take that to begin. But really, I want to talk about a lot of things with diabetes self-management education. And one thing I want to clarify on this is never to forget that last word, which is and support. The support and the long-term support of these patients is just so incredibly important over time. So I want to talk about the why, when, the who, what, where, when, how, etc. How we really need to do diabetes self-management education. So hopefully by the end, you're really going to take away some very important things. One is, when do you refer people for diabetes self-management education support? Where do you send them? And then understand the curriculum of accredited programs. So basically why you're sending them. So I think those are some important objectives that we can talk about as we move forward. So I'm going to kind of define what is DSMES, what's its history, when do you send people where, who are you sending them to, how do you actually physically send them, what education are they receiving, and then what is ongoing support? What exactly is that? And I want to pose a question then at the end, and then certainly accept some questions at the end as well. I hate reading my slides because you can sit at home and do that. I could have just sent you the slide deck and you can do that. But I think it's very important to read this. This is how we define, when I sat on the national standards last time, this is the definition we came up with for diabetes self-management education support. It's the ongoing process. And that second word is so important, ongoing, of facilitating the knowledge, skills, and ability necessary to diabetes self-care, as well as the activities that assist the person with diabetes in implementing and sustaining the behaviors needed to manage his or her condition on an ongoing basis, beyond or outside of formal self-management training. So you can, I think important words, ongoing process, sustaining on an ongoing basis. This is not a one and done type thing. You don't just get education, you're finished, oh, well, good, they're good for their next 40 years. They have to deal with this very complicated disease state. So I think that's really important. So this all started in 1984, believe it or not. Some important things happened over time. The ADA got involved, began recognizing programs and accrediting them in 86. Programs started using the standards that came out at that time. And then, we started doing some revisions. And unfortunately, as you can see, it went from 84 to 95 before the first revision. There was a lot of literature back then regarding such. This was a really important time for diabetes self-management education. That's when CMS started to actually reimburse for this very important and necessary service for our patients. And then the second revision, so they became a little more frequent, about every 5 years. We're doing some revisions. There was 7. So AADE got into the accreditation of programs back in 2009. I can't believe it's been a decade already. And they have accredited a lot of programs. So those are still the two accrediting bodies, ADA or AADE. The curriculums are essentially identical. but the accrediting bodies are different. And both of those societies work on these standards. So this whole idea of long-term support was added in 2012 when I was on the committee, and I thought that that was a very important aspect of things. And then certainly during this last revision in 2017, we agreed with that decision. So what is the recommendation? If you come straight out of the standards of care, I should update this slide to 2019, but all people with diabetes should participate in diabetes self-management education. So let me just reiterate that. All people with diabetes should participate to facilitate the knowledge, skills, ability necessary to do this. All people. And I'm emphasizing that for a reason. We're going to talk about the sad truth. So look at this. An estimated 6.8% of privately insured people diagnosed with diabetes actually receive diabetes self-management education. So just a little bit different than the all people that's recommended, right? 5% of newly diagnosed patients use their DSMES benefit in the Medicare population. 5%. And it's recommended for everyone. Only 1.7% of Medicare beneficiaries with diabetes had a claim in 2012. So it is really somewhat of a sad state of affairs that we have this great reimbursable and necessary process that's available that is recommended for all patients, and we're down in the 5% range of people that are actually receiving this type of benefit. Really, really, really sad. So when should we be sending people? So we did a real nice paper and talked about the 4 critical times that patients really need to be assessed. And one is certainly when they're diagnosed, annually for maintenance and prevention of complications. If they have a new complicating factor, and I'm going to talk about these individually, it's important to send people back. And then if there's a transition of care. So once again, reimbursement is there. There's no reason not to use this service. So at the time of diagnosis, let's talk about that. All newly diagnosed patients type 2 should receive diabetes self-management education. Ensure that both nutritional and emotional health are appropriately addressed in education or make separate referrals. So you want to make sure that these people are getting all of the education they need and deserve. And that includes emotional well-being as well. Annual assessment. So why this annual assessment? You really need to review the knowledge, skills, and behaviors of these patients, make sure they're sustaining and maintaining the benefits. Some people may have had long-standing diabetes with a limited prior education, so don't we want to build on that one-time education on a yearly basis? Guess what? Patients change over time, right? People are not static. So they change, they have different medications, they have different activity levels, nutritional intake. Their body has changed. They may have gained or lost weight. They may have, unfortunately, or not progressed in terms of their diabetes. It's a normal state of a disease, right? So these people really do need long-term education. Maybe they're out of target in terms of their A1C. And has that been individualized properly? Are they maintaining the outcomes? Are they having any unexplained hypo or hypoglycemia? Have they planned a pregnancy, or are they pregnant? And just the support to attain or sustain these behavior changes that they've been working so hard to achieve. And once again, weight, other nutritional concerns, all these things need to be updated on a yearly basis and discussed. Maybe not every time, but it's at least worth that assessment again by a specialist, a diabetes education and care specialist. New life situations. Wow, doesn't that happen to all of us, right? So new complicating factors. So this is the third reason. You may want to send somebody Maybe they got their initial education 6 months ago, or even their yearly education 6 months ago. And guess what? Something may have changed. They may have developed kidney failure or have had a stroke. All of a sudden, they've had a stroke. They yet can't use their current blood glucose meter because they can't use the Lancet device, or they can't inject their insulin properly. They need to be taught how to use a pen versus a vial, or whatever that may be. They've changed to some sort of complicated medication regimen. They're unable to take a basal GLP-1, and they've been switched to basal bolus insulin therapy. Wow, do you think that might require some education, as opposed to one injection each night and a weekly GLP-1? You're injecting 4 times a day and hopefully checking multiple blood glucoses in a day. So once again, lots of things change. They may have developed some depression, or what about just good old-fashioned diabetes distress that is so real and so important? They may have developed a physical limitation. Maybe they've lost their vision due to diabetic retinopathy, and now they need a meter, a speaking meter, or something like that. Once again, dexterity, movement restrictions. They can't walk due to a problem. You want to teach them how to exercise in different ways. What if they're having financial limitations, having access to food, other social determinants of health that need to be addressed, or they've had these major changes? There are times in between those yearly visits that you may want to send somebody for further education. What about a transition of care? So their living situation changed. They were in the hospital, or they've subsequently moved. They were in adult living facility and they've moved home, or they've moved out, or they were at home and they've moved into adult living facility of some sort. They weren't living alone, and now their spouse has passed away and they are. Wow, that can be a lot different. How much was that spouse really helping them, or maybe a daughter or someone that was assisting them in their diabetes self-care? Maybe a change in their medical team. Their endocrinologist retired, and now they're going to see their primary care doc, who may not have that specialization in diabetes management that their endocrinologist did. Insurance change, resulting in a treatment change. Oh my gosh, I had to change all my medicines. I had to go from a weekly GLP-1 to a twice-a-day GLP-1, or whatever that may be. And wouldn't these people deserve the education to go along with that? Age-related changes. I'm starting to forget to take my medication. How can you help me as a diabetes care and education specialist, or a CDE? How do you help me with that? We're having self-care difficulties. I can't check my feet anymore. I can't see the bottom. How can you assist me? And what about using a mirror or whatever that may be to actually examine my feet on a daily basis? How can I do that now that my wife isn't around to help me, or I can't reach my feet anymore? So how do you refer people? What is the referral process? It's fairly simple. All you need, it does require a healthcare provider's referral, but all that is really needed is the diabetes type. What's the treatment plan? What are they taking at this point from a medication perspective? And why are you referring them? Is this a new diagnosis, a yearly follow-up, a transition of care issue, or a change that requires an intervention in between? So, and I'm sure that they can send this to you, but this is a real nice site that has the AAD website showing a referral form, a sample referral form that you can use. And it looks like this. And basically, just fill that out real quickly to kind of start the education, diabetes care and education specialist out, so they have some information on the patient. They're going to build on that dramatically, and we're going to talk about the curriculum and what they do, but they're going to gather all kinds of information from the patient. But that's where you start somewhere. So where are you going to send these folks? Good news. It's easy to find. And once again, I'm sure they can send you this website as well. This is the ADA. This is how you can quickly find ADA recognized programs in your area. Just put in the zip code and it pops up all the ADA, and you can search by miles, etc., from your location or a patient's. And then here's AADE's website of where they can look at all these centers all over the country. 4,562. I bet there's one near you. Now, maybe not. And luckily, there is now we're starting to get some options for remote diabetes self-management education and support. So that may help for those, as you can see in the middle or that western part of the country, there are some sparsities, but we may be able to help with this remotely as well. And the last I gave this lecture, I was in New Hampshire, so I just did a map of New Hampshire and what theirs look like. So who are you sending? Who are these people? Who are these CDEs or diabetes care and education specialists that you're sending them to? Well, at least one of the team members is going to be either a nurse, dietitian, or a pharmacist with training and experience pertinent to diabetes self-management education and support. And if they are CEDE certified, every CDE takes the same exam. It is not specific to your training. So a dietitian, a nurse, a physician, a pharmacist, nurse practitioner, whoever that may be, all take the same exam. So they all have the same knowledge base when it comes to the education they're providing. Or it could be another healthcare professional holding this CDE certification, or even board certification in advanced diabetes management. So other healthcare workers or diabetes paraprofessionals can contribute if they have some appropriate training. So you could have even lay workers or care managers or other folks that can actually provide some of the education to the patients as well. So it really is a true team-based approach to care. Most centers have a nurse, a dietitian, that are both seeing them separately, one handling more the education regarding nutrition, the other one more regarding other things. But once again, they all have the same knowledge base and have passed that CDE exam or are on their way to taking that exam. So what are the roles? The professional team members, they can perform all of DSME. That is providing both the assessment as well as the education, while the paraprofessional team members can help maybe with instruction, reinforcement of those skills, behavior change support for the patient, can facilitate a group discussion of some sort. Maybe they're going to have a group discussion about foot care and can certainly facilitate that, or can bring in speakers that are not necessarily CDEs, but can provide that type of education. And then obviously the ongoing self-management support that we talked about that's so important, and the psychosocial support that these people need. So once again, the professional, whoops, that didn't forward, there we go. So what? When I say what, I mean, when I talk about curriculum. So what are we going to be teaching these patients? Because we really want to get into the specifics. So there's going to be a rather extensive assessment for these folks. Where are they in their disease process? Is this, a 40-year-old with an A1C of 6.1 that's just on diet alone? Or is this somebody 20 years into diabetes with multiple comorbidities and multiple complications on basal-bolus insulin therapy or pump? I mean, they're completely different, and the disease process and where they are in that large continuum is very different. So we need to identify that first. And then nutrition, where are they eating? Do they live in a food desert? Do they have difficulty obtaining foods? What do they like to eat? They like to, let's bring in a spouse so we can, educate people together if they have a support system of some sort or other family members. What kind of physical activities somebody do? Are they limited due to diabetic foot ulcer? So they're really unable to walk. They're non-weight bearing at this time on one of their feet. Or is this somebody that's very active, otherwise fairly young and healthy, and may be able to really benefit? What kind of activity can that person do? Do they have any limitations to their activity? I always love to tell a story. When I was in practice, I'll never forget. I had a lady, and I was speaking with her about her activity, and I recommended she started her walking routine. And she came back a month later and, how are you doing on your exercise? And she said, well, I really can't walk on the road. I live on a back windy mountainous road and there's no shoulder. It's rather dangerous. I said, we don't want you to get hurt. I said, is there a high school nearby that you could maybe walk around the track? She said, well, believe it or not, I'm fairly rural. It's 45 minutes to an hour just to get to the track. I'm like, oh my gosh, that's probably not ideal either. And what about a mall walking program? She said, oh my gosh, the mall's 2 hours away. And said, well, what about in your yard? Could you walk? Well, and then she said, well, I was outside the other day and there was a bear in my backyard. I could not believe. And she had legitimate reasons she could not. So all we came up with was walking around inside her house. That's all she could really do. But to have those conversations and discussions with her, that is actually a means of activity, is just to walk around the loop in your house or up and down the stairs if you're limited in that way. So I think it's very important. Are they using medications properly? What medications are they on? Is their injection technique proper? I have another anecdotal story I'll never forget. It was a woman came in to see us. Her A1C was 9.5, and she had been on ADA for over a year. Well, we discussed with her injection technique. Well, if anybody remembers ADA pen, you have to pull out the plunger and twist it and then inject. And that's how you get the dose. She was pulling out the plunger but never twisting it. And so she literally never injected herself with the medication the entire year that she was on it. As sad as that is. And we asked her about seeing the plunger move down and how she knew when it was empty. And she said, oh, every month I just threw it away and started a new one. So just think of the time, the waste, incredible waste of medication, and money, not just for her, but her insurance carrier. How much money was wasted on that medication, was thrown away for a year. All we did at that visit was teach her how to use the ADA. She came back in a month or two and she was doing much better. Her A1C had come down. And it was just literally that 10 minutes of education that we were able to provide. And if that had been done earlier, how much better this young lady would have done. Are they monitoring their blood glucose? When? How? Are they doing it properly? And more importantly, we're going to get into that. What are they doing with the results? And then what about complications? Do they know how to prevent them, detect them, treat them, etc.? So this is the kind of extensive assessment that's done in order to provide the proper education. We're certainly not going to teach someone not on insulin how to inject insulin. That would be silly. And so you have to do this extensive assessment on the front end. That clinical history that's so important. What about cognitively? Does the patient have some health literacy or numeracy issues that are going to affect our ability? Is this patient been put on a sliding scale with mealtime boluses and they're not good with math? Who knows what they're coming up with? And they don't have an app in order to put this data in. So what are we doing there? What kind of cognitive issues are there any that we need to work around, provide the education that's going to be successful then? What about diabetes distress? It's really prevalent. And do they have it? And do they even have a support system? Once again, do they live at home alone? They're a widow or widower. Their children live 3 states away? Or is this somebody with a strong support structure nearby? Or is this a lady that lives in the woods with a bear that we talked about earlier? And what kind of behavioral issues might they have? Where are they on that readiness to change scale? It's so important, right? We have to figure out, are they ready to change? Because trying to get people to change that aren't ready, you got to get them ready to change before you implement the change, or it's not going to work. And so much is important in this assessment. And these aren't done in doctor's office. I didn't have time to do these during a primary care visit of 12 minutes. When I ran the diabetes center, I had more of the time to be able to do these. And then formally, we were able to do these, the nurse, dietitian, myself, and pharmacist, to really spend the time with people and find out where they are. So what is the curriculum? So number one, the importance of preventing, detecting, and treating acute complications, right? We need to teach these people how to identify these problems. Hypoglycemia, I always used to talk about hypoglycemia. It's really important how to detect it and how to treat it, but more importantly, let's teach you how to prevent it altogether, right? And that's an important conversation and very important education that these people, once again, I like to use the word deserve. Hyperglycemia, man, my sugar's 350 or 400. What do I do in the acute right away? How do I manage that? DKA, very important now with the SGLT2 inhibitors, right? So what about DKA or euglycemic DKA, even maybe more importantly or as importantly, how do I manage that? What do I do? The sick day rules. I just can't keep anything down. What do I do with my meds? What do I eat? How do I manage that? Severe weather. I live in South Florida. We have hurricanes every year. What do you do? How do you prepare for that? Luckily, a week ahead of time it's coming. So how do you prepare in order to manage that situation and, that crisis supply management? And then certainly chronic complications. We've got to talk about, once again, how do we prevent them, I think is the most important conversation. But once again, what are you doing to detect them? Are you getting all the screening done that, once again, you deserve, which is going to include, does your provider examine your feet? If no, just take your shoes and socks off when you walk in the door. You're much more likely to get them checked. Wiggle your toes in their face. Maybe they'll actually check them. Don't wear your, I always told patients, when you're going to see your doctor, don't wear your, pantyhose up to your hips and, big boots that need to be zipped and undone and everything else. Make it easy and convenient to get your feet examined. And have you had a urine test for microalbumin? When do you see the eye doctor, et cetera? Really need to have those conversations and facilitate the referrals that may be necessary to get these things done properly. And then certainly immunizations are so important. Here we are in flu shot time. My wife's a nurse practitioner, does long-term care, and they're starting to see flu already, believe it or not. So certainly the curriculum, it reflects evidence and practice guidelines. Those are certainly taken into consideration as we write these recommendations. The needs for individual participation will determine the elements, right? So you're not teaching every patient everything. Once again, that would be a complete and utter waste of time to teach a patient how to use an insulin pump if they take metformin, right? So that's individualize the curriculum after the assessment to match the patient's needs. And that's really match those two up to make sure the patient's getting the right education at the right time. Problem solving. Really want to teach patients problem solving. What do you do with these blood glucoses? When do you check your blood sugar? What do you do with your ill? Let's manage behavior change, et cetera. That's really helped these people. Certainly AADE as their AADE 7, once again, goes into the self-care behaviors, pathophysiology, treatment options, et cetera. And once again, I want to emphasize the importance of individualized education plans to meet those patients' needs. Boy, don't we all need this? I don't know if anybody's been a patient recently. I had a kidney stone a couple years ago and ended up in the ER and hospital and everything else. Oh my gosh. I see myself as a fairly well-educated, intelligent person, and navigating the healthcare system for me was exhausting. And the bills and everything you get in the mail, and how do you do this? And how can we help our patients navigate this crazy system that we're all part of, unfortunately? And how can we teach them to self-advocate, to walk into your doctor's office and say, hey, you know what? You've never checked my feet before. Would you mind checking my feet? Or I understand I'm supposed to have a pneumonia vaccine and I need a prescription for that. Could you help me get that? Or I'd really like to have that urine test for microalbumin done. And to be your own self-advocate is so incredibly important. And some people need to be taught how to do that, because unfortunately, there is a lot of people still see that hierarchical instead of the important team-based approach to care when they walk into the doctor's office. And then e-health, how can we do that? And back to that third or fourth slide, this ongoing, lifelong process. This is not one and done. You don't come in the first time, get your education, you're out the door and finished. That's not how this works. This is a lifelong disease that progresses over time, that has potential complications, acute and chronic. Treatments change over time, etc. This needs to be lifelong, and we need to facilitate that for our patients. So let's just talk about the AADE7 self-care behaviors. I think they're really important. They're well written. They're well done. AAD's done a great job with that. So they talk about healthy eating. Very important, and this is part of every diabetes self-managed education curriculum is, carb counting and reading a label, and what is a portion size, and how do I measure that, and how do I reduce that, or what are ways in order to do this, and how can I fit a food plan into my culture, right? Rice is a very important part of my cultural heritage, and we have that frequently with meals. How can I manage that? Can I do different kinds of rice, or whatever that may be? And then how food is actually affecting their blood sugar. And to me, that has a lot to do with teaching people when to check their blood sugar and how to monitor and manage that data surrounding food and exercise and sleep, etc., and illness. And then certainly setting smart goals when it comes to weight loss. Activity. What is activity? You wouldn't believe, the conversations, and you've all probably had them too, with patients regarding activity and don't even really know how to exercise or what that even means. You can't tell someone, I want you to start exercising, talk to you in 3 months. It doesn't work, right? And we need to be really specific. Number one goes back to the assessment. What are you doing and what are you able to do? And then what's an appropriate goal? Is that goal to walk 10 minutes 3 days a week to start? Let's start somewhere, right? So it's smart goal setting and all the other things. And then watching your blood sugar related to this activity and checking at the proper times and using that data in an effective way. And this goes back to this monitoring. Number one, why are you checking a blood sugar? Just for the sake of checking it? Do you do anything with the data? I always said, it was my morning checkers. Those patients that would come in and they had this great logbook and they checked their blood sugar every morning religiously, 7:30 a.m., blood sugar check, fasting, 110 or 100 every single morning. But their A1C was 8.5. That's not when I need you to check. We have got to change your habit. You can probably check in the morning once a week. Why don't you do some paired testing or checking before and after supper once a week, or vary it around? And that's change the way. That's get some data that's actually usable, that we can find out when you're high, when you may be struggling, when you may be having lows, so we can use that data to change your treatment plan, whether that's with diet, exercise, or medications. How do you use your meter? I'll tell another sad story. I had a woman come in, her A1C was high as 9 or so, first time we saw her, and looked at her logbook, and her blood sugar was always great. Her blood sugar was always, in the 110 to 125 range. So we said, well, how do you check your blood sugar? And she took out her control solution, put a drop of it on her finger, and tested it. And that's how she was actually checking her blood sugar. She was just checking the control solution each time. Nobody ever taught her how to check a blood sugar. And I don't think she even had a prescription for Lancet. And that's how she came up with this, because nobody gave her Lancet. So she didn't know how to even get blood. So she was just checking the control solution. So once again, so important to teach these people how to properly use these devices we give them. You know, they may have never seen it. We see, 30 of them a day. Of course we know how to use them and assume other people do, which is just not the correct way to do it. So once again, when to check, how to interpret the data, what do you do if it's low or high, and causes of falsely elevated readings, did you wash your hands after you poured the syrup on your grandson's pancakes or whatever, or the jelly off your fingers, or are you testing that instead? And so really important to educate people surrounding all those things. Taking medications. I talked about the injection issue that woman had with the Byetta. I could tell stories all day, anecdotes about people that unfortunately were not properly taught how to use their devices. So how do I take my medication properly? What's the best time of day? We have the oral semaglutide coming out. There's some significant restrictions as to when people can take that. And so we have those conversations. When should I be taking this medication? How do I properly do that? How do I use an injection if that's what I'm on? And then let's talk about side effects and how these medications work. What about insulin? Can I just leave it in the car when it's 90 degrees? How about how we manage this medication, especially those medications are at risk of going bad? Can I reuse that needle? No, you can't. They're one and done. So all those important things that we need to educate patients about. Problem solving. You told me to get those ketone strips. Well, what do I do with them? Or and more importantly, what do I do with the results once I use a ketone strip? Do I need glucagon? If so, what do I do with it? How do I inject it? Or how do I use the nasal spray now? So much easier, right? It's a really nice addition to our armamentarium. So how are you dealing with these highs and lows, and how do we manage it? And more importantly, how do we prevent it? How do we solve problems? Oh my gosh, I'm going to have a colonoscopy in the morning. What do I do with my medications the day before, or when I'm drinking the solution to prep for the colonoscopy? What do I do with that? What about activity level? The days where I exercise in the afternoon, I get low. So do I need to adjust my medications on the days I'm going to exercise? And what can I do? And can you help me with that? And boy, I can't afford my medicine. What can I do in order to manage that? Coping. We all need this, right? So once again, even beyond that depression, diabetes distress, just the fact that, I remember reading a study, this was, my gosh, 15 years ago, that somebody with diabetes on insulin thinks about their blood sugar every 15 minutes. I mean, that's distressful, right? I have other things to do. And I'll never forget, one time I was at a conference, and there was a woman sitting in front of me with type 1 diabetes that had a continuous glucose monitor and a pump. And I was watching her, and she could barely concentrate on the lecture because she was continuously either looking at her CGM, grabbing food out of her bag, fiddling with her pump. I mean, it was like almost a nonstop thing with her dealing with this. And once again, how much distress can that cause? And how do we help people better cope with that? And what resources are out there, and what can we do to engage in long-term support for those people in order to help them cope with this difficult disease for years and actually decades. So reducing risk. So how can we prevent these complications? Everybody keeps scaring me with the complications, or I had an uncle that lost his leg, or a sister that went blind in her left eye, or whatever that may be. And I'm concerned about these complications. And how do you talk with patients, and how do you, well, number one, relieve some of the fear, by providing them with risk reduction strategies, right? So I understand your grandfather had lost his leg to diabetes, but maybe it was partly due to his smoking as well. And why don't we talk about that, and not smoking, and checking your feet on a regular basis, especially if you have neuropathy, and getting that eye exam. Maybe your sister that lost her vision didn't see the eye doctor. They weren't able to identify this as a very, very early, where this can be prevented. The progression of retinopathy can be prevented, and how to listen to your body. So once again, how do we talk to people, give them strategies to prevent these long-term complications that, once again, can contribute to the distress we were talking about earlier? And then once again, individualization. DSME will be, identified and leads the participant with assessment and support by one-on-one DSME team members. So we're going to individualize for each patient that walks in the door. They're going to get the curriculum that they need, and that fits them. Participant DSME team members will develop an individualized DSMES plan. So this is really patient-centered care. It's shared decision-making. It's everything, all those important things wrapped up in one, right? Interactive teaching. We do not like to do just static lectures with the PowerPoint like we're doing today. This is necessary for this type of interaction with a large group remotely over the entire country. But certainly when you're one-on-one with the patient, or you're with a small group, and facilitating that and doing goal setting and action plans and that shared decision-making, I think is so incredibly important. You bring that patient in and find out where they are, readiness to change, using teach-back methods and motivational interviewing. All this stuff is so incredibly important. And then that behavioral therapy and behavioral change, and how we facilitate that for people. So especially with this patient generated data, with CGM and BGM and all this data, how can we teach people to change their behavior by looking at all this data coming in? It can be somewhat overwhelming for people, and instead how to use the data to change behavior. Really, really important. So there is technology-enabled diabetes self-managed education support. There's lots of data about text, SMS messaging, apps, social media. People can be very empowered. Proves A1C. There's data to support this, and I have some references down there. But very important to know that technology can enable this in certain people, especially from a remote, if they're remote. So how often is the patient in your office, right? So 99% of their time they're at home by themselves. And how can we use technology to motivate people all those times they're not with us? And can that be used through technology and even through a coach, etc., as part of that long-term ongoing support? So let's talk about support here before we get into questions. So certainly it's important to provide those folks with what options are available. Either, years ago was in your area. So what, is there a support group, or what is there maybe a church group that has people get together? Or what is this long-term support? It was kind of an enigma years ago, but now it's much, much easier with the social media aspect and the possibility of remote patient monitoring and the apps, etc., that can really supply this support over time, and to talk with the patient to find out what works best for you. Do you really like to sit in a room with other people? Is that a good way to support, or do you like, text reminders to say, hey, remember to eat, 5 vegetables today, or whatever that may be. Remember to exercise today, or the remote patient monitoring that we can do and provide that kind of support. So once again, in order to talk to those patients, to be able to find out what kind of ongoing support they want, and then how to implement that and sustain the ongoing, once again, we want to sustain the ongoing skills, knowledge, and behavior changes needed to manage your diabetes. That's what we're really trying to accomplish at the end of the day. So once again, I'll say it again, not one and done. So just get those strategies available for the patient. And then with the goal setting and setting those goals, we like to use SMART goals. So very specific, measurable, achievable, realistic, time bound. And that really goes back to that example I was using earlier of the exercise or activity. So very specific. Mrs. Smith, well, I think we've agreed today that you said that you could walk 10 minutes, and you said you could do that. You have the time to do that each day, and that's a realistic goal for you for the next 2 weeks, and then report back to me and let me know how that went. Or your health coach will reach out to you. So once again, those very specific and SMART goals, much different than, Mrs. Smith, I want you to start exercising. See you back in 3 months. Doesn't work, right? So it's really use those very specific, measurable, achievable, realistic goals so that we can move people forward. Behavior change is such a key to important outcomes, and holding patients accountable, making them set their goals, assisting them in that, and then making sure they're meeting those behavioral goals over time. Providers will monitor and communicate back and forth with patients if they're achieving those goals, etc. And we can obviously change goals, add goals, and further facilitate that change over time. But this is part of diabetes self-managed education, is that, once again, following people over time, making sure that they're achieving what they want to achieve. So I have a very important question at the end, and that is, why would you not refer a patient for diabetes self-management education and support? Now, once again, let's look back. It's recommended everybody get this, and roughly about 6% of people are actually receiving this type of care. And after outlining all that and discussing that, I hope that this is a very rhetorical question, because I don't know that there's a good answer. Unless you're in a nursing home on your deathbed, everybody really deserves to have this type of education. So I really like to open up for questions and answers. I hope that we do have time. We have about 5 minutes left, so that's great. And I'm available afterwards if necessary.
Thank you, Andy. This was an outstanding presentation. Thank you so much. So for those attending, you can either type your question in the question box, or you can use the raise hand icon, and then your line will be unmuted.
So can I get off my soapbox now? I literally was standing on my soapbox here in my office giving this lecture. Can you tell? I'm a true believer.
So let me ask Fide if we have any questions. Fide, do we have any questions?
No, not yet.
Okay, just wait for a few seconds. In the meantime, is there any study or data on why only 6% of these patients really take advantage of the diabetes self-management education program?
I think a lot of it is a lack of that referral on the front end. I don't think people are actually getting referred. I think that's a lot of it. I think some of it is reimbursement issues, because even though there is reimbursement, if people have high deductible plans or they're still in their deductible, they're maybe less likely to pay for education as opposed to the end of the year where they may have met their deductible, and so now it's just a copay. sometimes I would see historically the copays are not, patients have difficulty with copay, et cetera. So there could be some reimbursement issues, even though it's reimbursable. And so I definitely have seen that in the past. There could be the good old time constraints for folks, and to be able to provide this remotely and at times that really meet the patient's schedule, I think is important. We used to provide education in the evenings for patients that worked and that type of thing in order to vary the times a little bit. And so it's really important. So I think some of it's the lack of referral on the front end, and some is the patients maybe not understanding or seeing the benefit, especially if they're having to write a check for that. So that would be my anecdotal. I don't know that that's scientific data. That's me anecdotally answering that question.
Thank you.
Sorry. So we have a raised hand by Judith. I'm going to go ahead and unmute her.
All right. Thank you.
Judith, you've been unmuted.
Oh, no. Can you hear me?
Yes.
Yes. Good afternoon. Can you hear me?
Yes, we can.
Yes, ma'am.
Oh, yes. Thank you. Yes. My question is, I'm working with aging community, and about this program, I thought it's very important, and I would like to ask you, because caregiver they don't have access to check the sugar for elderly in the morning, and they don't have a nurse who come every day. So I don't know how we can address that because they can't do it by themselves for some reasons.
Right. And so that's really important, right? So that goes back to the assessment part, where that educator is going to be able to sit down with that patient and assess, well, why can't you check your blood sugar? And maybe there's a different meter or device that we could give you that you could use. Could you be surprised? Maybe it's, they have a real small device, and some of the test strips are tiny, and it's a dexterity issue that they can't literally pick up those tiny little test strips and put them in and there's other meters that are specifically designed in order, there's 100 meters on the market. A lot of times you can find one that may have a bigger test strip or may have a way to easier for the patient to actually utilize and be able to check it on their own if they were to be able to spend the time with the assessment and the education from that diabetes care and education specialist to come up with a solution to that. So I think it all comes down to the assessment and having that expert be able to find the solution to that one individual problem. So I did want to make one last point before we finish up, and that is, I think it's really important. There is one piece of work that that the providers really need to do, and that is to really find that education center in their local area, meet those educators, network with them, and refer. And you're much more likely to refer to somebody if you know them, if you've met them, if you've seen the work that they've done. And maybe it's the educator's responsibility to be going out to these primary care and these other docs to introduce themselves, develop that relationship so that they can actually, start to build that team. And the team doesn't have to be in the same room, right? So that team could be the primary care doc with a group of educators across town, but that they feel comfortable with and communicate with and can facilitate one another as they care for this patient together. So I think that's the one job that we have to get, whether it's your health clinic or whoever that may be, to develop that relationship to make the referrals much more comfortable and easy.
Excellent advice. Thank you, Andy. Do you have any another questions?
No, not yet.
All right. There's some few last minute items. Those attendees, please complete the post survey after this webinar is over. Your responses are very, very important. so we can improve our webinar sessions. And if you have any additional questions for Dr. Reinhardt, please make sure that you can send it to us, and then we make sure that he gets the questions and you get your answers. So it's 2:04. I would like to thank Dr. Andrew Reinhardt for this outstanding presentation. And if you have any additional questions, just make sure that you send it to us. Thank you so much and have a great afternoon. Thank you.
Thank you.
Thank you.
Have a good day, everybody. Bye.
Bye.